And if you want to do that, you must do what is called as a test of significance. And if you look at the modern statistical concepts of tests of significance, they're very clearly outlined in our Anumana Pramana. In fact, there is a much more detailed way of explaining this, but since there is no time and that's not the purpose of our discussion, I'm not going into it. But they were clearly aware of the concept of specificity. Avyabhijaritva. Like if the two events are to be causally related, they first say that it is an observation, that two events are related. From that observation, it has to become a consistent correlation. And that correlation has to be later established as a causal relationship. And that causal relationship can be established only by the tests of significance. That the two events should be specific. One event should be specific to the cause and effect. There should be sensitivity. Sensitivity means avinabhava sambandha. It is not that sometimes the cause is there and sometimes the effect is not there. You should have a consistent observation of cause and effect relationship. And ayudha siddhatva. This is the challenge de-challenge method. If you challenge the system, you de-challenge it, then the other thing should disappear. One exists, the other will exist. If one disappears, the other will also disappear. This is today famously called as the challenging de-challenging system. So logically, I think Ayurveda was also very well advanced when it came to understanding causal relationships. So this should be the foundation of our research approach. Now, when we came to the clinical trials, there was a big question whether our clinical trial design is acceptable in Ayurveda. But again, when we look at Anumana Pramana, if you want to establish causal relationship, our acharyas clearly said that you must look at the Paksha, Sapaksha and Vipaksha. Paksha is Sandigdha Sadhyavan. If you have a doubt whether something works or not, if there is a relationship, that is called as a Paksha. Now in modern terms, that is the context of a trial drug. Where there is a doubt, where there is a hypothesis, that is Paksha. And what is Sapaksha is the positive control, where you already know that such a correlation exists. And Vipaksha is a negative control, where you know such a Nischida Sadhya Bhavavan Vipaksha. So in principle, even the logic of a clinical trial is not against us. So why I am telling is that when we wanted to develop a research methodology which would be compatible with Ayurveda but also acceptable to science. So we had to look into all these kind of concepts. So this is the design, is that can we preserve the holism of Ayurveda and the rigor of science at the same time? Can we come up with a research methodology that will be rigorous in scientific terms but will not compromise the holism of Ayurveda? So with this platform understanding, it's also important to understand that if you look at holism, I think it's taking long. Can I take another 5 minutes to conclude this? Huh? Yeah, because time is not in my control. It's moving much faster than I expected. So this doesn't work. Yeah. So this is the. Oh, that was better. See, if you look at holism, again it needs definition. Now Ayurveda is a system which accepts reductionism. It is so holistic that everything gets accepted. So even reductionism has a place. So that is why there is lot of variation in the way Ayurveda is treated. A physician can even treat with a single drug. It is not in principle against Ayurveda, but provided there is a logic for using that, even that will get accepted. So we find that if you look at Ayurveda, holism when we define, there is one level of holism when we move from molecules to whole herbs. If you are saying instead of using reserpine, I will use Rauwolfia serpentina, that is one type of holism. But it is not the total holism of Ayurveda. Now if you move from a single dravya, which is very rare in actual classical Ayurvedic practice, to one formulation, that is again another level of holism. Then a single formulation to multiple formulations, it is another level of holism. And if you bring in this logic of changing the medicine during the course, makes it even more complex as a holistic approach. Now multi-formulation to multi-model, if you include therapies and other things, then that is another level of holism. Now the last one is if you also include mind, body, self and other things, yoga, then it becomes holism at a much bigger level. So this entire concept of holism in Ayurveda is multi-layered, and it is important for us to understand what level of holism we are working. So in our study, the level of holism, it was not, we cannot claim that it is completely holistic, because in actual practice today Ayurveda is not also practiced in that holistic way. We used it was a movement from, instead of single formulation, multiple formulations were used, but not internal therapies also, because the study would have become too complex. So because a physician was confident of managing through Shamana Chikitsa at this stage, that was a challenge, and that challenge succeeded, which I think is a good part of the story. The challenge here was to do a study of multiple formulations using an RCT design. So here we have rigor. A meta-analysis is the highest level of evidence. Meta-analysis means you do 5 to 10 studies, then do a comparison of the results of all those 10 studies, then it becomes. But RCT is otherwise, as an individual study, RCT is the highest level of evidence. So an RCT model to do, this was the challenge. Now, when we looked at our treatments, at least 148 formulations were selected. See, it is important to understand that no serious RCT study has ever been done in the world involving scientists of the caliber of Dr. Daniel First, where a physician allows the patient to use 148 formulations. Because in a clinical trial, you have to start with one medicine and end with the same medicine. Here, not only are we giving different medicines to the patients, every time the patient comes, we change the medicine. So we were jokingly saying that in allopathic treatment, when the medicine doesn't work, they change it. In Ayurveda, when it works, we change it. Because its work is over, we have to give another medicine. If the patient moves from Sama to Nirama, there is no point in again continuing the other treatment. We have to now go to another stage. So the sequencing and changing medicines stage-wise was a very important component. And Dr. First understood this, and in order to avoid what is called as a Hawthorne effect, the situation was such that the allopathic physician wanted to see the patient only once in 3 months. They would probably see in such a short trial, sometimes only thrice, once at the baseline, then at the midpoint, and then at the end point. There is no need for them to see in between, because it's the same medicine being given, and unless there is a big problem or they don't need any observation. But our physicians told that we want to see them every 15 days. So in order to avoid a Hawthorne effect, because if one group, allopathy patient doctor alone sees thrice, Ayurvedic physician sees more time, there will be a bias in the study according to them. So in order to make it similar, the allopathic physician was also forced to see the patients every 15 days, although he did not have much things to do. So which means that Ayurvedic physician was given the freedom to choose whatever medicines he wanted, on whatever diagnosis he thinks was okay. But Dr. First has told that at the first study level this will work. But after 2 or 3 studies, we are not able to explain why you are making these changes, then you will end up with a block. Means communication will not happen. Your treatment may still work, but it will not serve the purpose of communication. So that is a challenge before us now. So these were and we used 6 types of medicines, the Kashaya, Arishta, Leham, but mostly because this was in the early Samana stages, Gridas and all were not used much. Because as it was mentioned earlier, you need to prepare the patient before ghee can be given. Because Ayurveda agrees when modern medicine says that ghee can cause cholesterol. But we also disagree with the same thing, because it is depending on how you use Grida, whether it becomes Visha or Amrita. Our texts have clearly told that Grida can be Visha. Not just cholesterol, it can kill the patient if you don't use it properly. But if you use it in the right metabolic situation, then it serves as Amrita. That is the secret which Ayurveda has understood. So both the observations are correct. But in our treatment, again, we could find that the physician was following the classical logic, because it was in the Amavastha that the patient was treated. The usage of Grida was very minimal. It was not used much. Mostly it was Kashayas and Aristas, which is one of the reasons why our placebos worked also. So I'll come to that part. We had to use, So before we come to that, the modifications that were made from our side was that we were allowed to use many formulations. We were allowed to change it patient by patient, stage by stage. But from the scientific side, they also insisted we should do certain things. Otherwise, it will not be acceptable to them. One of which was enforce double blinding. This is an area where I am still not so convinced. Because if the Ayurvedic physician needs to change medicines every 15 days, he has to really understand what medicine the patient is taking. Or he is very likely to guess if something goes wrong, that this, because the more precise you are as a physician, it's very easy for you to judge whether it was a real medicine or not, because 15 days later you are expecting a change. If it doesn't happen, it's very likely that he is part of the placebo group. In this study, probably because of the short period, this didn't become a problem, but I'm not sure that in the future double blinding may always be possible if you allow the physicians to change medications frequently. Because that every 15 days when they see the patient, they may gradually begin to see one group which is consistently not responding to your medicines. Probably the only reason is they are not getting it at all. So blinding is an issue. It didn't create a problem in our present study, but I'm not sure. Then randomizing the patients. And a very important aspect was developing and administering placebo. This was one of the major breakthroughs in the study, is that we tried to make dummy medicines of our classical preparations. Now this has never been tried before. There have been attempts to make placebos for individual formulations, but all our dosage forms like Kashayam, Arishtam, and one of our colleagues actually was also familiar with the food industry. He tinkered with some food additives and water and came up with things which worked. And there are still problems with the placebo if you want it to be consistent, shelf life and all that. But the thing is, it worked. So we developed Kashaya placebos, Arishtam placebos, not for each Kashayam, but for all Kashayams there would be one placebo. For all Arishtams there would be one placebo. And then for Gutikas also, some of them have problems, but the interesting thing is that it really worked in the trial. And one of the ways which we ensured blinding was to include patients who did not have prior exposure to Ayurvedic treatment, at least for 1 year, full-fledged Ayurvedic treatment. Because if they had just tasted real Kashayam and come, they might possibly distinguish between a placebo and. So by doing this, we found that as Dr. First would say in his own words, that the blinding study was successful.
So we have here evidence that for the very first time, full Ayurvedic outpatient therapy can be done in a controlled trial.
Okay, so this is one of his most important conclusions, is that it is possible to bring science and Ayurveda together without compromising science, which is what he is very much excited about. That we could demonstrate that you could use the most stringent RCT design. I don't think that it is necessary or even possible to study every Ayurvedic intervention, because this pilot study itself cost us 1 crore at that time. If you are going to study each and every intervention like this, it is not possible. But the thing is, what we need is a proof of concept, as they call it. If at least 5-6 interventions like this are proven, it will change the way modern scientists think and understand Ayurveda. So we are only looking at proof of concept designs. It's not that, because even RCT trials are not possible in modern medicine always. They are very expensive and they are limited to a small population. One of the main reasons why modern drugs fail in the post-marketing surveillance is because the sample size is too small and the population doesn't really represent the entire community. So when they come into the PMS, methotrexate for cancer becomes a drug for rheumatoid arthritis, or thalidomide. All those lessons are there. So there is also a big debate in modern research circles itself as to whether RCT is really the ultimate design. But then it is still very powerful. So if we are able to show at least in a few diseases that using the RCT model we can prove Ayurveda works, then it will create a kind of breakthrough in communication. So that is the only purpose. So now this study, there are only a few more slides. It's a double-blind, randomized, placebo-controlled. It's a controlled placebo-included pilot study. There were 3 groups of patients. There were only 15 in each group. The actual numbers are a little different because there were dropouts and all that. One group received a combination of both allopathy and Ayurvedic treatment. Another group received only Ayurvedic treatment and allopathic placebo. And the third group received real allopathic medicine and Ayurvedic placebo. So every patient felt that they got a combination of both Ayurveda and allopathy. That was the blinding purpose. And when we did the success of blinding study, we found they believed that they had got, all of them, in the required kind of proportion, believed that they got a combination of both. So we were successful in blinding them. So these are the names of the scientists who actually worked in this. So these were the inclusion criteria broadly. Less than 7 years. The treatment group were methotrexate. Ultimately there were 14 patients in that group. In the Ayurvedic group there were 12, and in the combination group there were 17 at the end of the trial, because there were dropouts in some cases. Yeah, this is I talked about all these 3 arms again. These are the placebos, decoctions, medicated wines. I already explained that. Yes.
And if we were going to do a controlled trial, we had to have placebos for each of these. This has not been tried before, and I must tell you that the pharmacy for Coimbatore did an incredible job in developing these placebos. You can see that whether it was the allopathic physician, the Ayurvedic physician, or the patient, they guessed incorrectly 1/3 of the time, exactly what you would expect if this was truly a blinded study. So we are able to prove that using full Ayurveda, we can do a double-blind trial. Now this is incredibly important for your science, because if this can be shown, it means that you can go ahead and you can develop studies which then will be credible globally. Of this trial, this is really what I think is the most important part of it. The results are interesting, but this proves that Ayurvedic therapy can be done in double-blind manner.
So, this is one of the real breakthrough of this study is that we were able to arrive at a research design which becomes acceptable to kind of both sides. Now, the outcome measures, again, as I said, it was all allopathic, because we did not have, it was only the physician's judgment, based on which the improvement was assessed. We hope that in a future trial we would be able to, in the near future. In fact, when Dr. First is going to come in May, one of the issues that we are going to discuss is to also develop Ayurvedic parameters, which of course he has asked us to do. He has nothing to contribute there, which will bring in more transparency from an Ayurvedic point of view. And our challenge is to see whether at least a small group of Ayurvedic physicians who represent the same school of thought can do almost the same kind of treatment and produce the same kind of results. This is going to be very important for Ayurveda as a system. Otherwise, it just becomes individual achievements. If it has to become an achievement of Ayurvedic community, then we have to do this kind of a multicentric trial. If there was 50% improvement, we found that the Ayurvedic group gradually became less. And actually 70% improvement, there was nobody in the Ayurvedic group at week 24. So actually there was a big debate in the beginning of the study whether the duration should be 6 weeks or 6 months or 9 months. And the physician, he was very clear that it should be actually 9 months. I still remember the debate that we went to, at 6 months was not sufficient. Now this judgment, very crucial. If we had decided a 6-month study, this would have been the result. This is why I want to mention that when you do research, it should be based on the clinical practice of Ayurveda. The clinical judgments and observations should come in deciding the research studies. This would have been disastrous. After all this, and it would have been a repetition of the WHO scenario. At 6 months, they will say 20% is the improvement Ayurveda can provide. But as we go into week 36, that slide is trying to escape. We will not allow that to happen. So that shows that effort we need to really prove that Ayurveda works. But this is very exciting because you find that at week 36, 20% improvement in Ayurvedic group is 100%. Very strong kind of observation that a larger study we'll have to repeat this. It gives you a very strong indication that Ayurvedic therapy needs. The real changes are happening between 6 to 9 months, which was what the physicians, like Dr. Ravindran, who was involved in the trial, we had to get his opinion as to how long should be the duration of the study. And this was so crucial. I mean, when we saw this result, I was feeling some shiver in my spine, because if we decided that it was 6 months, then the entire study would have collapsed. So the 33%, the highest respondents, ACR 70. Now this is because there is no equivalent to methotrexate that has ever been observed in a clinical trial to provide this kind of results. So you can see what Dr. First himself wants to say about this. So what is interesting here is that on the whole, we can only say that Ayurveda was as effective as methotrexate, which itself was an exciting finding, because there was no, and with less than half the adverse events associated. The methotrexate group had more than half of the adverse events. Now adverse events and side effects are different, because we noted all negative observations that the patient had gone through. So they were not necessarily due to a treatment. Somebody had a fracture, it was adverse event. Somebody sneezed, it was adverse. But overall, numerically, the adverse events in the Ayurvedic group was much lesser than in the allopathic group. Because even without therapy, you can have an adverse event. So we have to do a more stringent analysis to see how much of this adverse event was really linked to our therapy and how much was it incidental. But what was interesting was that the combination group did bad. So it doesn't look sensible to combine methotrexate and Ayurvedic treatment. But I have an observation is that the combination that we do in clinical practice is different from what we did in research. In clinical practice, it is an intelligent combination, because I think Dr. Ravindra would also agree from our practice, is that we cannot stop allopathic medicines immediately. He never advises that. We have to wean them off. But what is done is the allopathic and Ayurvedic regimens are balanced in an intelligent way. In the clinical trial, it was done in a blinded way. So there was overdosing of both Ayurvedic and allopathic. So I wouldn't say that we shouldn't combine, but definitely this is not a good way of combining, because maximum side effects were found in the MTX group, and even the clinical response was much less in the MTX group. So one of the conclusions in future studies, we will not combine methotrexate and Ayurveda.
Any regimen that has methotrexate in it had twice as many side effects as Ayurveda.
So that is his observation on side effects.
It shows that there is a way to do classic full Ayurveda in placebo-controlled trials. And 2, it indicates that there's a chance that Ayurveda works just as well as standard therapy. We'll see what it comes out, but we're going to go on and try and get the funds to do the large trial. So what does this tell us? First, it gives us a real handle on the variability of response of these measures. So when we do a larger trial, we can say this is how much variability we expect, and so now we can say scientifically how many patients are needed in the bigger trial. Second, and surprisingly to me, I didn't expect this, the combination did not do any better than the one therapy or the other. Consequently, in further trials, I don't think it's appropriate to look at the combination. All we have to do is compare standard therapy to Ayurveda.
So I think that's the gist of the whole outcome.